Great. Hi, guys. John and I are just chatting here. Didn't realize we were live. This is Buffy Wicks. So excited to be here today. Really excited to have John on. John Swartzberg is a clinical professor emeritus of infectious diseases and vaxology at UC Berkeley School of Public Health. And prior to that, he was the past director of the UC Berkeley UCSF Joint Medical Program, and continues to teach in that program in the Division of Infectious Diseases and Vaxology. So we're just thrilled to have him here. He's a homegrown local expert and has been working on these types of issues for decades. And so we're real thrilled. And I know he's doing a lot of these conversations with folks in the community. And I'm just thrilled to have him here. So John, thanks for taking the time. Thanks for being here. I'm going to start off with a couple of questions that I know that we have fielded a lot in my office. And that I field a lot when I'm, just talking to folks, generally speaking, and then we'll take some questions from folks from Facebook so we can try to answer as many questions as possible. And just as a reminder, this conversation really is focused on the health aspects of COVID-19 and the pandemic that we're in. There's obviously a whole bunch of other conversations around the economic recovery and how this is impacting small businesses and, accessing unemployment insurance and a lot of other things that our office is very, very involved in. But for the purposes of this conversation, we're going to be talking specifically about the healthcare aspect of it. And so please keep your questions in that vein if you can. And we'll have more of these as well, talking about other topics. But one of the things I want to start off with, John, is just kind of bigger picture. How well are the efforts going here in California to flatten the curve?
I think quite well. Now, quite well means we're doing a good job in a very difficult circumstance and with still lots of people getting sick and tragically some people dying. But California has, for reasons that aren't completely understood, weathered the storm better than most other states. And that's been very encouraging. And
one of the things you hear about in terms of the numbers that we're seeing is that we haven't tested as much in California versus other states. I think New York's done a lot more testing than we have. And so how much is testing an indicator of our success versus kind of hospital rates and death rates? How do you look at that data and figure out what success means?
Right, that's a really important question. There's no question that California has under-tested the population. I think there's a great story there somewhere in terms of the question why we haven't tested more. Mm-hmm. And it doesn't have to do with the lack of will or wanting to test more. It has to do with the lack of availability of testing material. So the data that we have here is tempered by the fact that we haven't tested enough people to really appreciate how widespread this disease is. And when we have more data like that, it's going to cut both ways. For example, the case fatality rate, if we tested a lot more, that would probably drop our case fatality rate because the denominator would be so much larger. On the other hand, it may falsely suggest that California is doing as well as we are doing. That is, we may have many more cases that just have not been recognized.
That we just don't know about, right?
Exactly. So, but even given that we haven't tested enough, I still think we have enough data here to say that California is doing better than we anticipated doing, given, let's say, a month ago when we started looking at modeling.
And is that data from hospital rates and death rates? Is that how you analyze that?
Well, the best data, which still isn't perfect, is death rates. Right. A lot of people, particularly early on in this pandemic, were dying at home and they were from COVID and they weren't given that diagnosis. And reporting is still spotty. I was just on a conference call today with with a group of people from another hospital, and they were still talking about who should report the death to the county. So each hospital is doing it a little bit differently. So the data about deaths is spotty, but it's the best data we have.
And I read some articles, and I can't remember if this is California specific or nationwide. So forgive me. That's why we have you as the expert on. That death rates were potentially being underreported. Do you think that was happening, and do you think it is still happening, or do you think there's more of an awareness around it?
Well, I think we're getting a lot better at it. We started working on a lot of the kinks. Now people are dying at home. The coroner is required to investigate to see whether that's a COVID case and report that. So I think the data is becoming more accurate and will become more accurate. From an international standpoint, the data out of China is unfortunately not as reliable as we would like.
Yeah.
And pretty good evidence that it's been markedly underreported there.
Mm-hmm. So going back to the testing questions, and I know the governor did a press conference, I think it was this past weekend, maybe about 6 or 7 days ago, really focused on the testing issues, the lack of capacity that we've had, some of the challenges that there have been faced. I mean, I'd read an article in the New York Times a couple of weeks prior that the sticks of the swabs, it has to be a specific kind of stick, and it was made predominantly in a factory in northern Italy where they were having a lot of these issues as well. And you're hearing those stories where the supply chain concerns around the actual production of the test kits. And then there's also the backlog question around getting these tests analyzed quickly so that you don't have folks waiting a week, 10 days before they know if they actually have the virus. Have we seen progressive movement in getting more test kits out and being able to ensure that we can, get the tests to the folks that need them, and particularly our healthcare workers and our frontline workers?
Right. There's been a dramatic increase in the testing over the last 3 weeks here in California. We really made a lot of progress, but there's still an awful lot of progress to go to where we need to be. And when we talk about testing, we're talking about two different kinds of testing. The most common one, the one you're referring to, is where we're looking for the RNA, the genetic material of the virus itself. That's the one where you have to stick the swab up through the nose to the back of the throat, which is quite uncomfortable and somewhat risky for the person who's performing the test. The other test that we haven't really rolled out at all yet, or hardly at all, is the antibody test.
Mm-hmm. And do you foresee these types of testings being so prevalent that it's commonplace that you're getting tested automatically, irrespective of, for instance, the serology test or the antibody test? Do you think we're going to be in a place where that's going to be an expectation similar to like getting a checkup, that you'll end up having to go do it?
Yeah, I hope so. And there's no reason why we shouldn't be in that position.
Yeah.
The question is when, not if. And the projections are all over the board for that, but the most recent one I saw was probably by sometime this summer, maybe even late summer, before we really get to very robust testing.
And, I've also seen differing reports. I know originally, I think the CDC had said, 18 to 25% they thought potentially were asymptomatic. I think Dr. Fucci upped that number a little bit, said maybe even up to 50%. Do you have a sense of where you think that asymptomatic population is, or do we just not have enough data yet to understand that?
Well, we don't really have enough data, so that's why everybody's speculating. But I think Dr. Fauci's guesstimates are pretty accurate. I mean, 25 to 50% is a big range, but that's probably where we're going to wind up finding most of our, 25 to 50% will be our asymptomatic carriers. Yeah.
Mm-hmm. Okay. Just moving on to everyone's now learning all about what we call PPE, personal protective equipment. And if you hadn't worked in the healthcare industry until this point, maybe you didn't know what that meant, but now everyone's talking about it. And the reason they're talking about it is because I think for many of our healthcare workers, they have not been protected in the way they need to be from the virus, for a virus that spreads so easily. We're hearing a lot, obviously, about N95 masks and all the other kind of accoutrement that go with being a frontline healthcare worker. I've had a lot of folks call my office about this who work at hospitals, who are very concerned about their own health. They're concerned about being exposed at their line of work and then going home and exposing their family, some of whom have, live with folks who have compromised immune systems or are caring for their elderly parents, or any number of different stories. And it's abhorrent that we haven't been able to protect our workers in the way that we need to be. Do you see that changing? I know the governor made a big announcement recently, but in your sense of, as you're talking to healthcare workers, is that finally reaching down, getting where it needs to be in terms of the equipment that we need to make sure that they are protected in our hospitals and in our clinics?
We're starting to see that now. And I think we're going to see marked improvements in that over the next 3 to 4 weeks. But I'm already starting to see some glimmers of hope in regards to not just the N95 masks, but some of the other material. I mean, I was talking to hospitals where just a week ago, they were just about out of gowns, for example. So there's still a fundamentally great problem with this, but it is starting to get better. I have to add to that, it is no one that I know who's been involved in medicine for even a few years ever would have believed that the United States would have been in this position of having a dearth of adequate PPE for our healthcare workers. It really verges on the criminal.
Yes, I agree. It's been heart-wrenching to hear some of these stories. And I know, we've had frontline workers who are looking for sublets because they don't want to go home, or they're living in their basement or their garage. They don't want to expose their family. I know the governor just made a big announcement yesterday around making hotel rooms available for free or very low cost, which I think is critical for the workers who are out there. And I know we saw a lot of terrible stories coming out of Italy of folks coming out of retirement to work in the hospitals who then caught the virus and unfortunately passed away. Or being exposed in that way, and them not having the protective equipment as well. How would you compare right now? I guess this is a two-part question. What happened in Italy versus what's happening in the US more broadly, and then what happened in Italy versus what's happening in California?
Yeah, the closest we can get in the United States to the experience in Italy is New York City in the last couple of weeks. They saw a surge that exceeded their capacity to adequately care for their patients and to protect their healthcare workers. It was really a disaster area in New York. We're just now starting to see some improvement, but New York has a long way to go. California, we've really been very fortunate, and it's not fortunate, it's due to the active work of our government, frankly, and our public health people. We haven't seen a surge that has exceeded the capacity of our healthcare system. As a matter of fact, the surge has remained significantly under the level that we were worried about. So when we talk about a shortage of a lot of equipment, we have to recognize that a lot of the PPE, for example, was being reserved for that surge that we were worried about. Ventilators were being reserved for that. Routine hospitalizations for elective procedures were canceled to make sure those beds were there. Now we can relax a little bit, not completely, but we can relax a little bit because it does not look like there's going to be a surge in California that's going to exceed our capacity.
And why New York is like Italy? Do you have thoughts on, did they just not get ahead of it in as much time as they needed? Did it come in undetected essentially? And maybe the density of the city and the sort of, I don't know, can you explain why you think New York is sort of the epicenter?
Sure, there are a variety of hypotheses. The most likely, or the one that probably carries the most weight, is that California sheltered in place earlier than New York. The Bay Area was the first large metropolitan area in the United States that went into shelter in place. And then the state of California, well, then Los Angeles County, and then right after that, within 2 days, the state of California went into shelter in place. And it was nearly a week, not quite a week, but just almost a week after that New York did. And you may think, well, it's a week, how big of a time difference is that? But when you look at where that curve, and it's going up logarithmically, you can see that in 5 to 7 days, your numbers are going to be dramatically different. So a big explanation for why California is doing better than New York certainly has to do with California sheltering in place earlier, and the Bay Area doing better than other regions, some other regions of California, like Los Angeles, for the same reason. Certainly another reason is the population density that you mentioned. New York City has a population density of roughly about a third more than the city of San Francisco, New York City. So in the city of San Francisco is 17,000 people per square mile, and New York is 28,000 people per square mile. So from the perspective of a virus, you need to find people who are uninfected and not immune. And the more dense the population, the more people you can find, so it's going to spread much more quickly. There was something this week in that was reported that I think is very interesting, and we don't understand the significance of it yet. But it looks like the virus was primarily introduced into New York City and New York exactly.
Right. Yeah, I read that article. Yeah.
Now, it's not clear what difference that would make because the West Coast, first Washington, then California, was introduced from Asia. So the introduction was different, but I think we still, at least I'm not able to fully understand what impact that would make, but it's an interesting observation.
And do they analyze that? Is there like different strains of the same virus? Is that how they're able to tell where it comes from?
Right. You look at its genome or the genetic material, and there's slight differences, and you can compare those. And the differences we see tell us where it came from.
Where it comes from, but it's the same virus. It's just
same virus, slightly different genetically. Right.
Got it. Okay. Switching gears a little bit, I would love to have a sense on upcoming, an understanding of down the road treatments that are being discussed. I know the president, who I'm going to refrain from really commenting about right now because I want to remain civil, but in my opinion, he's done a horrible job at all of this, and I don't trust him at all. I think he's a terrible president. But anyways, has talked about different potential medicines that have, I think, proven not to be successful, or the jury's out at least on if they are. I've read some other stuff. Israel's doing some interesting things in terms of treatment. I think there's a lot of experimentation going on right now to figure out kind of what works. What's your sense of kind of treatment right now? And are we getting closer to understanding how if we do get it, and if we are one of these folks who are immune compromised, how we can actually be treated other than the ventilator, but something that can actually help our body fight it off?
Right. Yes, having a drug to treat this would be just fabulous. There are, as you're saying, there are quite a few studies that are ongoing right now. A remarkably large number of studies to try and answer that, given how short a time we've had to deal with this virus. The evidence to date about hydroxychloroquine, either alone or combined with azithromycin, is discouraging. The data that's come out is certainly the science is inconsistent with what the president has been saying. Just today, the New England Journal has a lead article that's coming out on remdesivir, a drug that was used to treat Ebola, and was developed here in California. And it wasn't a case-controlled trial. It didn't compare remdesivir patients with other patients. But that said, the preliminary data that was published today looks fairly encouraging for that. Not, again, we have to have a control group to see, but that I put right towards the top of a potentially effective drug, but we're not going to know for a while about this.
Mm-hmm. And what about a vaccine? I've read that it's 12 to 18 months at the earliest that we'll see a vaccine. If we'll see a vaccine, my understanding is coronaviruses to date haven't really been successful with vaccines. Can you shed some light on the probability of that and the timeline and what your thoughts are?
Right. There are over 50 trials that either have started or will be starting very soon on different vaccines. There's never in the history of our species where we've, in science, where we've ever done anything like this so quickly. It's possible that all 50 of them could flop. And that's just in the United States, by the way. There are a lot of international vaccine trials going on. So it's possible they could all flop. It's also possible that we could hit the jackpot with that. We just don't know, and that's why we have to do the studies. If one does work, it's not going to be available. I think the earliest would be around 14 months from now, looking at how long it would take, not to establish whether it works, but to establish that it works well enough and that it's safe. So safe and effective are the keys here, and that you can't rush. You have to test it in a lot of people, and you have to gradually ramp that up. So I think, yes, there's a good chance we could develop a vaccine. You're right, we have never developed a vaccine against coronaviruses, but there's nothing unique about that virus that precludes us from developing a vaccine.
That's good to know. I was hoping you were going to say something like, we've tried repeatedly with other coronaviruses and it hasn't worked. But is it just that with other coronaviruses there hasn't been the need like there is now? Is that why it hasn't been developed prior?
There hasn't been a real robust effort like we're seeing now.
Like now.
There was effort with SARS because for a while there we didn't know what direction SARS was going in, and SARS has a mortality rate that's probably at least 3 times this particular virus's mortality rate. But it didn't spread person to person as effectively as this one by far. The immunity to SARS that we developed, natural immunity, those people who survived the infection, appeared to last about 3 years. That's encouraging and discouraging. It's encouraging from the perspective that if we could get a vaccine to do the same thing, 3 years would be pretty good. But we'd really like something that you could get a vaccine for today, like a measles shot, and protect you for the rest of your life.
Right. But it could be something more like a flu shot where you do it every season.
It could be.
Who knows? Yeah, we don't know.
Exactly.
If we don't get a vaccine, how do we handle this? Is it just our society changes forever in terms of until we develop, I guess, enough herd immunity, or what does that look like? What does a world like that look like if we don't get a vaccine?
Herd immunity. It means that we'll continue to have to hunker down like.
And can you explain herd immunity for folks who are unfamiliar with the concept?
Sure. It's the idea that if enough people are immune, then the virus won't have a good place to go. And so the numbers of people that get infected are going to dramatically drop off. But you need enough people immune, and you need those people immune for long enough. And those are still some question marks. But what I think one of my colleagues who I've taught with now for 25 years at Berkeley, he thinks, and I think he's right, that we're going to see this virus become what we call endemic. That is, it's just going to be part of the background noise that we live with. It's going to change our behavior. It already has dramatically changed our behavior, and that will change our behavior more chronically. But not to the extreme we're seeing now, but we may just have to live with this virus, not nearly to the extent that it's spreading now, because we'll have enough herd immunity. But it's going to always be there. So if we don't get a vaccine, that's what we have to anticipate.
And is there definitive research coming out around if you have had this virus, you've recovered? Do we have a sense yet now of kind of how long and or if you are immune to date?
No. We have I think most people in my field think that our immunity, well, first of all, we know people recover, and the vast majority of people recover. And they recover because they have an immune system that works against it. So we know that our immune system does work against this virus. What we don't know is the antibodies that we test, whether they correlate with that immunity. And we don't know how long a duration that immunity lasts.
Yeah.
It could be very short-lived. It could be a year or 3 years. Against SARS, it was about 3 years.
And I've seen some experimental treatments that are going on right now of taking folks who have had it, who have survived, who are fine, taking their plasma and doing giving that plasma to folks who are sick. And the research I was reading was it's better to do it on the front end of catching the virus. The earlier, the better, it seems. But it still seems like the jury's out in this. Do you have any other updated information on that idea?
No. Yeah, not really. The studies are ongoing right now. I read yesterday an anecdotal report of 15 cases, and the doctor, this was an infectious disease doctor in the United States, and he said these patients got better more quickly than he anticipated. But as you said, the earlier people are given that, the more likely it is to be helpful.
Right, but again, this is anecdotal. It's 15 folks. It's hard to know. Yeah.
Right.
The other, what we're also starting to see is media reports of, I read a story of a baseball coach in Long Island who was 30 years old, didn't have any pre-existing conditions, ended up dying of it, right? You see, and of course, I think the media is talking about those cases a lot because it puts the magnitude of it, I think, for young people in really stark terms. So it's not just something that impacts older people, but it's something that impacts younger people as well. I know that it seems though, and if you look at the death rate, that's not the norm, right? It's older folks. But do we have a sense of why a case like that, someone who's 30 years old, who's been in good health and doesn't have any pre-existing conditions, would have such a severe reaction that would result in mortality?
No, we just don't.
Yeah.
But you're absolutely right. The mortality rate, the most recent data coming out of the United States, if you were 19 or less, there were no case fatalities. Now, that's worldwide. We do see rare case fatalities in children, but they are very unusual very unusual. And then as you get older, the numbers start to go up, but they're not dramatically going up until you get above about 60.
Okay. So I have two more questions for you, and then we'll open it up for folks who are streaming in. One that I care a lot about, it is honestly, I would be very candid with you, has kept me up at night. And I've read some of these accounts, but I have a 3-year-old. I'm 24 weeks pregnant. My husband and I are here in our house, very quarantined. If we both get sick, what do we do with our child? You know, who's going to take care of her? And if we both get really sick, you know, I can't have my parents watch her. How do we as a family unit navigate these types of situations? You know, the idea of hiring someone to come in and help, you're putting them at risk, you know, like what are the options that you have as a family when this situation arises?
Well, Buffy, you have just identified a real hole in our society.
Yeah.
How we take care of each other. There's not a good answer to your question. And your question could actually be expanded. It's not to a much larger group. What about in your home? You probably have several bedrooms. So if you got sick, you could sort of self-isolate.
Mm-hmm.
What about people who don't have a home where there's several bedrooms?
Right.
Several family members in a very small apartment. What are those people going to do? So you've identified, you've asked a question that I don't have an answer for. And it's sad that I don't have an answer for that. It's sad that we as a society don't have an answer for that. But it begs the larger question, and that is, why are we seeing such significantly high mortality rates in underserved people in our communities?
Yeah.
The lower socioeconomic groups. You know, we're apparently not seeing it in African Americans in California, but nationwide, African Americans have a much higher mortality rate to this. And there's nothing about being African American that puts you at greater risk in terms of genetics. Right.
No, the racial disparities, it seems that there's more and more information coming out on that needs to be addressed. Yeah. I mean, I think we see those disparities across healthcare. You know, women of color die more at childbirth, you know, longer life expectancy. You know, it seems like that unfortunate and tragic trend is continuing on in this vein. But it is frightening to think about, you know, what do we do? What do we do if we get this and we have children? So my last question for you, and then we'll open it up for questions from the audience. So say we seem to be doing okay here in California, all things considered. Now, I know that the data still it's not perfect data, right? But it seems like we're, you know, flattening the curve or as much as we can. You know, what does the rest of the year look like? What does next year look like? If it's going to take 14, 18, 2 years to get a vaccine, however long it is, are we going to have waves of this type of sheltering in place activity? Is that going to kind of come and go as outbreaks happen? Or what is your sense of, just so our folks can understand the next year or two, what our life will potentially look like?
Right. First of all, I want to just make sure when you say we're doing okay in California, we are doing okay relative to some other states.
Right.
We still have a significant problem in California.
We're not doing as well as New Zealand. That's for sure, right? Yeah, yes, right. Yes.
That said, there are a variety of scenarios that people talk about, but I think what's very likely that we'll certainly see in California, or as certain as I can be, and we'll likely see in other parts of the United States, is that we're going to slowly bring people back into the workforce. At the same time, hopefully, simultaneously, we'll have a robust testing system. We'll have enough tests and a way to test an adequate number of people, and enough trained people to respond to the results of those tests. What I'm getting at is that as we send people back to work, we need to monitor what's happening with the epidemic. If we're starting to see the numbers go up again, then we're going to have to pull back on the people going back to work. If the numbers remain low, then we can continue to put more and more people back into the workplace. So I think what we'll see is this initial big hump that we had, picture a roller coaster, but the next really ride on that roller coaster is not going to be nearly as steep and not go up nearly as high. And then it'll come down, and slowly over time, we're going to see those bumps get less and less and less. Given that we're able to monitor very carefully, we have adequate PPE for people, that we're able to act on cases, start identifying contacts and making sure they go into quarantine. So we need an aggressive public health approach simultaneously with the reentry of people into the workplace. And the last people that will enter the workplace or start to leave this hunkering down are people at highest risk for morbidity and mortality. So people my age, people with diabetes, chronic lung disease, heart disease, hypertension, obesity. These are people that seem to be at much higher risk, and they would be the last people to enter the workplace. So I think that's what we're going to see. And then, of course, if we get a drug, that's going to change the game considerably. And then if we get a vaccine, the whole game changes.
Right.
Yeah.
Right.
Actually,
no, go ahead.
There's just one other point I wanted to make about that. The other thing that could change the game, earlier I briefly mentioned antibody testing. If it turns out that the antibodies we measure are protective, and if it turns out they're protective for, let's say, a year or months, then we could identify people who are antibody positive and say, you're okay. You've got a free ticket to go back out because you're not going to get infected again, at least for months and maybe for longer. Right. So that we could add on to our schedule of bringing people back on.
Well, that is actually a good segue into a question that we've gotten from someone here online. Lori Dare asks, when will people who think they have had it be able to get those antibody tests?
I've heard that some different doctors' offices are advertising that they have them available now through some testing companies. I think you have to be very careful with that. We have to be sure that these are tests that have been approved, that they've gone through rigorous testing to make sure that they're accurate. The last thing you want to do is get an inaccurate report. Mm-hmm. If it was me, I would wait a little bit until we see a lot of these tests coming out from very highly reputable places. Stanford's starting a test. I think they may have either just started it or will be starting it this weekend. I know at my school at UC Berkeley, my colleagues in the School of Public Health, they're going to be starting a really interesting test with antibody studying. So there's going to be quite a bit of antibody testing coming out from very good sources. So make sure if you get antibody tested, you make sure you're getting it from a reputable source.
Great. Next question is from David Simon. He says, I have a 3M N95 mask that I sprayed with isopropyl to sanitize before I read that alcohol defeats the mask's electrostatic characteristics. Question is whether I'm better using the compromised N95 mask or just making a bandana out of whatever, a scarf.
Right. Well, I think most anything's better than making a mask out of a bandana.
Okay.
We can talk more about homemade masks if you want, but the N95 mask is really not something that's necessary for the general public.
Right.
Anyway. And yes, it's a very important observation he made, and that is that when you try and kill the organisms on it, for example, by spraying alcohol in it, will that change the electrostatic forces, which is important because that's what keeps viruses out. So it may decrease the effectiveness from being an N95, meaning it filters out 95% of viral particles, may take it down to N85 or N80, still more than enough that you need unless you're working in a hospital setting with a patient with COVID where things are being aerosolized.
Great. And then for the rest of us, we've purchased some face coverings that we saw an advertisement on, my husband and I did, just to have something. We don't want to obviously purchase N95 masks. I don't even know if we could, or surgical masks, or things that are probably better protected. Is that enough for an average person who's going to the grocery store?
I think it's important to remember that the masks primarily protect you protect other people from you. If you wear the mask, you're less likely to infect somebody else. We don't know how much less likely, but you're less likely to infect somebody else. So wearing a mask,
it keeps the droplets closer to you.
Yes,
that's what you're doing.
And the less porous that mask is, the thicker it is, the fewer pores it's going to have, likely the more effective it's going to be. It would make sense. Wearing a mask to protect yourself, it may offer a small modicum of protection, and I would underline may, because we're not certain of that. But it also, I worry about the fact that wearing a mask gives people a sense of that they don't have to be as careful, that they don't have to practice as much social distancing. And the answer to, and don't think that way. The most important thing you can do by far
is social distance,
is social distancing, and then you can talk about a mask.
Right. Okay, let's see. Ashley Brown asks, how will COVID-19 pandemic change the healthcare and medical system we currently have after this?
Well, I would really hope that it changes it in two fundamental ways. From a public health standpoint, public health in the United States and public health in each state, and I'll speak here, public health in California, have been profoundly underfunded for decades. Mm-hmm. I started practicing infectious diseases and internal medicine in Berkeley and teaching here in 1975. At that time, the California State Health Department was a place that people came from all over the world to see because it was so renowned. It remains an absolutely wonderful health department today. But the amount of funding it gets today relative to what it got in 1975 is dramatically different. And the same thing has happened with every public health institution, e.g. the CDC, dramatically underfunded. The people who work there are outstanding, real smart, well-trained, but the depth of people we just don't have anymore. So one of the important things that should change with this pandemic is to recognize that we can't afford not to fund public health. You know, and I'll get off the soapbox in 1 minute, but
you can have the soapbox as long as you want.
Okay. The United States doesn't have any problem funding the world's largest military, and only a fraction of the number of people in the military are fighting. The rest are there to protect us in case there is a war, in case there's something that threatens us. And we're willing to pay the price to keep that standing military in case there's a problem. Yet we haven't been willing to fund public health to do the same thing. And now we're seeing the consequences. We're seeing terrible consequences of that. So that's number one. Number two, the other important thing that should change the way we practice, the way we have medicine is delivered in the United States, is that this should be the final nail in the coffin of the way we have medicine delivered today in terms of spotty, in terms of major discrepancies in who can get care and who has access to care, and people getting impoverished because they don't have access to care. So I hope this is the final nail in the coffin of that old way of thinking that just does not work. I hope that the social disparities that we've seen with this infectious disease and with every time there's an infectious disease that we're seeing today, I hope people can see that this is just not right. It's just not the way we should be living with each other. So I'm hoping that this will help push forward a
more comprehensive, well-funded system. Yeah,
exactly. So those would be the two big changes in our healthcare system: public health and a better way of funding and assuring that everybody has the right to care.
Yeah, I've talked about this before too, across the board. We can't go back to normal because normal wasn't working. You know, we need to actually think about our healthcare system, our paid leave policies, our paid sick day policies, you know, our tenants' rights. I mean, there's a wide variety of things that this pandemic has really highlighted where we have a lot of vulnerabilities as a society, and we need to think bigger and bolder as opposed to saying, let's go back to the way it was before, because the way it was before wasn't working for a lot of people, particularly low-income people, you know, communities of color, you know, those living on the brink of poverty, et cetera, right? So I'm with you on the soapbox, John. Thank you.
I love the way you put that. And I really hadn't thought of it quite that way. Is, you know, I keep hearing people ask me the same question, when are we going to go back to normal?
Yeah.
And I haven't been answering the way you just did, but you're absolutely right. You know, there are a lot of things about normal we would like to go back to, but there are a lot of things about normal that we shouldn't.
That weren't working.
Yeah.
Yeah.
My wife and I were talking the other day about, will we ever shake hands with anybody again?
Right.
I'm not so sure I will shake hands anymore.
It's hard to. I'm a hugger, you know. I
know.
I've had to like stop all the hugging.
Right.
Okay, so let's see. Another question. Zawah Sophia Ahmad asks, is domestic travel by flight safe when necessary within the US? And as a related question, Miriam NG asks if people are getting tested when they get on and off planes, and or maybe is that something like that could be in our future in terms of border, or like, are we going to have different kind of border controls when we're not controls, but like, is that going to be an automatic part of going through customs eventually or crossing the border that you foresee?
Sure. Well, let's first talk about flying. Right now, it's probably fairly safe to fly if you didn't have to go through an airport to get to the plane. Although I understand the crowds at airports aren't nearly as bad as they were before. So the danger of flying is really going through the airport, touching a lot of different things, having people very close to you, and then getting on the plane the way it was before. That normal was, not anything anybody liked to do in the first place because you're so crowded. Today, if the airplane, I talked to somebody who flew from New York here about a week ago, and there were 3 or 4 people on the plane. So,
right.
But the question is really an important one. Flying is, both because of the airport and the plane, is not a safe thing to do. It incurs a risk. How big of a risk, I don't know, but it incurs a risk. Sometimes you have to take that risk. And there will be reasons where you absolutely have to take that. You should do all the precautions, but and it's not an enormous risk, but you're adding on a risk. Right now, I wouldn't feel comfortable flying unless there was some emergency I had to deal with. The other question about testing in terms of when you get on the plane or off the plane, that's not going to really help. I mean, it might theoretically help if you tested somebody with a 5-minute test, and if it was positive, you wouldn't allow them on the plane. Although they might not be contagious because the test doesn't test for the intact virus, it tests for the RNA of the virus. And the RNA of the virus is not contagious, it's the intact virus. That's more of a nuanced point, but it's important to recognize. Testing when you get off the plane is not going to help because if you got infected on the plane, it's going to take several days for you to even have the test positive.
Right. And what other kind of, I saw in China, they have these fever tents, and I had heard stories around, every time you walk into a public building, you're getting your temperature checked. Do you foresee those types of things coming into our future?
Maybe. I've been consulting with some large corporations, and they're planning on bringing their people back to work at some point. And a lot of them are talking about thermal screening when people come back in, and anybody who has a fever would be called out and talked to and make sure that they actually do have a fever, and if they do, don't come to work. So it may play a role. It's one tool. It's not a profound tool, but it might be a useful tool in certain circumstances.
Mm-hmm. Okay. Let's see, moving back to our questions, Dara Abrams of Berkeley asks, can COVID-19 be passed from infected humans to common household pets, dogs and cats, among those pets, and then to other non-infected humans? So I think human to pet to human. And what's the evidence here? Suspicion seems to be that it first transferred to humans from animals.
Right. It's clear that this virus came from bats. What we don't know is whether there was what we call an intermediate host. That is, it came from bats to another animal, and that animal then spread it to humans, or did it come directly from bats? For example, SARS came from bats to a cat-like animal called civets, and then to human beings. And there may have been other animals too, but we don't know that yet. As a matter of fact, we don't even know what animals were in the open markets, the live markets in China, because the Chinese haven't told us, and they haven't told us whether those animals have been tested. So there's still a lot of question marks there. The question about your pets, dogs and cats, there are reports of cases. I know of 2 reports in the literature of dogs and the humans that live with the dogs had COVID and spread it to the dogs. The dogs did not get sick, but they did find the virus in the nose of the dogs, in the mouth of the dogs, but they were not ill. What hasn't been studied is whether if somebody coughs on the coat of a dog and then you go and pet the coat right afterwards, could you get it on your hand and then take your hand to your mouth or nose or eye and then spread it to yourself? That hasn't been studied. It would seem to me that if you pet somebody else's dog, it might be a good idea to wash your hands afterwards, but the threat would be.
But if a dog has it in their nose and their mouth, what if the dog licks you, rubs its nose up against you, you're a non-infected person? Could that potentially?
It theoretically possible. I read a report from a professor of veterinary infectious disease at UC Davis, and he said that couldn't happen, but I don't know why he said that. So I would say it's theoretically possible, but quite improbable. There have also been a report of at least 2 cats catching the virus from the humans that they live with. Those 2 cats did not get ill, but they were able to isolate the virus also in their nose and mouth. So it's important to remember this virus has figured out a very good way to infect human beings and spread from one human to another. It doesn't appear to cause disease in animals. And there's no evidence that animals spread it to us. I can't prove a negative though. I can't prove it's not possible.
Right.
And there's finally the report of the tigers in the zoo. One tiger the virus was isolated from, and the tiger had a cough, but so did multiple other tigers in the zoo, and the virus was not isolated from them. So we don't think that was that represented true transmission, or that the tigers were transmitting amongst themselves.
Okay. Another question here. This is from Taku Imagawa. Hope I pronounced your name correctly. Are there any studies being done on how vulnerable people living with HIV are impacted by COVID-19?
There haven't been any large case series published yet, but there's been a great deal of discussion in the HIV literature about how will people with HIV handle this disease. Right now, the most information I have is from what's called an emerging infectious disease network from the Infectious Disease Society of America. And I've read a lot of anecdotal reports about HIV patients, and those whose HIV is not well controlled with medications, they did not seem to handle the virus as well, which is not surprising. Although it's not, I think the jury is still out on how people with HIV who are on medications, whether they would handle it any differently than somebody without HIV.
Okay. Brett Isis Fisher asks, we have a relative in hospice and hospice workers are balking at treating our relative because they do not want to go into the care facility. What are patients' rights here?
Patients, well, I'm not sure, I'm not speaking as a lawyer, I'm speaking as a physician, and I would think that, I know that the code of ethics for physicians would be that you take care of any patient who needs you, regardless of their infectious disease. And I know so many physicians, and they all would respond that way. And they all, and I think we know from just reading the newspapers, they are responding that way. And the same holds for not just physicians, but nurses and respiratory therapists and all the other healthcare workers, including the janitors. You know, they're all putting themselves at risk. So I think somebody who calls themselves, somebody who is a hospice worker would surely have the same ethical responsibility and would surely be carrying that out. Now, humans have, there's a wide spectrum of how humans behave and do things. And I'm sure there are some doctors and nurses and respiratory therapists who would balk at doing that. That would be the minority, I'm certain.
Yeah, okay. Just a couple more here and then we'll wrap up. This is a question from Lance Morgan of El Sobrante. What protocols are established to protect our seniors in assisted care facilities? And obviously we've seen recent issues here in the East Bay of these facilities getting COVID-19. That's obviously such a vulnerable population, and then their family aren't even able to come and check on them. What's being done on that?
Well, nursing homes have infection control procedures that are that should be enforced and are enforced by the health department. But the health department, as we talked about earlier, is sorely in need of personnel, and so it's not enforced probably as well as it should be. And nursing homes suffer from the fact that the people who work in them are very low paid, often have to have a couple of jobs to make things work for them in terms of food on the table. So people in nursing homes, well, and then I'll add to that that a nursing home is a perfect environment for the virus to spread in because you've got a lot of elderly people, mostly elderly people, who are completely dependent upon other people to care for them. And these other people are coming from the outside. Mm-hmm. So it's a perfect setup for a storm unless there's meticulous infection control. Infection control in nursing homes is, if it was carried out as is written, it would work very well.
Right. Yeah, it seems I know the governor talked about this today. He did a press conference at noon, and I know this was the topic of conversation. So hopefully we'll get more information out to folks about it. But the stories you're hearing from these facilities is really tragic. And
it's not just the East Bay. On the peninsula and down in LA, there have been several nursing homes, and the numbers of people infected in these nursing homes, the one in Orinda, it was the vast majority of people there got infected. So something broke down. That's clear that something broke down in infection control.
And what I've heard some other health care providers talk about is how tragic it is that these folks are dying alone, and how difficult that is for those caregivers to watch that happen. And it's really, really, really sad. So hopefully we will do what we need to do to protect. These are our most vulnerable, some of our most vulnerable folks. So, but again, I know the governor did do some, did talk about that today. So hopefully there's more action on it. Okay, Carl Mace says, some people have been exposed and recovered. They've recovered from coronavirus. They now have antibodies. Is it safe for these folks to start socializing, going back to their sort of normal-ish life? In China, I know they're issuing green health certificates on people's smartphones. What are your thoughts on, so if someone has recovered already now, what they can be doing?
Sure. Before I answer that, I wanted to go back to what you were just talking about before.
Sure.
Just one little thing. Today, this morning, I attended virtually a funeral of a dear friend of mine's wife who died of COVID. And the funeral was virtual because we couldn't go there. So it was just heartbreaking.
That's very sad. I'm sorry.
Yeah, so the answer to the question, I really sort of answered before, and that is, until we know that the antibodies that we're measuring are protective, you don't have a green light to go back and think you're immune. And so we need that data desperately. And it's going to be available to us soon. What does soon translate to? In terms of whether they're protective, maybe within a couple months. How long they're protective, that's going to take many months to a year or two. So the answer is no, I don't think you have a green light to go back. My guess is that you do. My guess is that they are going to be protective, but we need science to tell us that.
Okay. Two last questions, then we'll let you go back to saving the world for us. One is second to last question is from Kim Wilson. I have a patient who believes that food in refrigerators is not safe, even after a 3-day quarantine, because the refrigerator keeps the virus alive. Same with the freezer. Can you comment as an expert?
The virus seems to survive best. It has a range of temperature that it survives best in. It does survive well in cool environments. At least other coronaviruses don't survive well in very hot environments. That's why we see the coronaviruses that cause the common cold to drift way down in the summer months. We don't know whether we're going to see that with this virus. But in studies that have been done with this virus, not very many studies, but in studies that have been done, that optimal range is not in the freezing area. And it's really not even in the refrigerated area, although the refrigerated area is more marginal. But freezing area is not an optimal range for that virus. So I think that it is probably fine to eat food that's been frozen for 3 days. As a matter of fact, it's important to realize that there's no evidence that this virus is spread by food. It's not a foodborne disease. This virus evolved to spread in a respiratory fashion, not by eating. So I think the energy about food is perhaps a little too much.
And just to clarify, because I've seen a lot of different things on this as well, if, you know, we're ordering out from restaurants, if someone who has it coughs on that food and we eat that food?
It's theoretically possible you could get infected. Yes.
Okay.
I mean, it would be
but
like, go ahead.
No. But, you know, it seems like there's just a lot of unknown. I mean, I'm continuing to order from restaurants and, you know, and there's also a lot of concern people going to grocery stores. What if I touch something? And obviously that's the hand washing piece, but the Amazon delivery box, do I let it sit out for 24 hours in my front porch? Is that stuff, what's your recommendation on those types of things?
The first thing to remember is the most important thing you need to do is social distancing. If you've done that, you're really protecting yourself in the most profound way you can. Everything else we're going to talk about is sort of at the edges of this. But why not at the edges of this? Why not protect ourselves in the maximal way as long as it's feasible? So we know that cardboard, the virus can live no more than 24 hours on. That study was pretty good. Is paper the same as cardboard? Probably. We don't know for sure. It wasn't studied on paper. So you could leave the paper out. The paper bags, don't touch them if it's not perishable, what's in them, for 24 or 48 hours, or even 72 if you feel more comfortable. Surely the virus will be gone by then. Surely it's probably gone by 24 or much less. So you have to sort of pick where you want to fight those battles.
Right. And with the biggest one being social distancing.
The biggest one being social distancing. Yep. The next is washing.
And hand washing. Yeah, exactly. Okay. Last question here from Ashley Brown. Will Buffy be doing another one of these, but with other intersectional issues, economy, community, incarceration, minimum wage, economic recovery, small businesses? Yes, we're going to be doing more of these regularly to bring in experts who have more expertise than I do on these issues. And as always, my office is open. We are doing a lot of work right now with constituents on accessing resources and all kinds of things. So please feel free to reach out to me directly. John, I really appreciate you being here today. I thank you so much for the work you've done your entire career. I know when you and I spoke yesterday, you said something like, you know, you're sort of 50 years in the making of sort of training for this moment, you know, and so thank God for you. For putting all that energy and time into this, and for being an expert and helping us, you know, see the path here. It's greatly appreciated tremendously. So I just wanted a big thank you to you. And then for everyone who dialed in today, be safe, physical distance, wash hands, all the things. You know, we're all in this together. I know this situation is harder for some than others right now who live in different types of circumstances. So my heart goes out to you all, and let my office know if we can be of help. But thanks again, John.
You're welcome. And I want to give an enormous shout out to our real heroes. And those are our healthcare workers.
Absolutely. Who are on the front lines every single day.
Yep.
All right. Thanks, everyone. Have a good day.
Thank you, Buffy.